Thank you, Kidney Warriors, Sundara, Marianne, and others for calling me to coordinate this session with family physicians. In fact, I must acknowledge that family physicians are true doctors, in my opinion. I am a so-called subspecialist. I'm not a doctor. In fact, when my mother was unwell, she would call and tell me, Sundar, do something. I say, see a good doctor, a family physician, not me. Because in most countries, except India, where the patient walks in directly with some sort of kidney disease, they just walk into my chamber and invariably every week I see one case of kidney swelling. And you know what that is? It is a hydrocele. They think the man has got kidney, the woman has no kidney. They think the scrotum is kidney. Invariably, one hydrocele or once or twice would come with kidney swelling. So that is the problem we have in our community. So at this juncture, I would acknowledge the help of all the family physicians. You are the pillars of our profession, and I wish we have a system like the Western world where no patient can walk into the specialist directly without a referral from a family physician. I think that will make a lot of difference. I think that concept is going off, and I find as a nephrologist in the field for 40 years something not good. I think we should encourage more of family physicians to be in the field. Now, some of the things, we talk of chronic kidney disease. You are Dr. Padma, and you are Anuradha. Dr. Padma, I think you have been in the field for more than 20, 30 years. Do you think in the last 20, 30 years, the incidence of kidney disease has increased? I know that we don't keep statistics, to be honest, but what is your feeling over the last 30 years in your practice? Do you think the incidence of kidney disease has increased, in your opinion?
Yes, sir. The kidney disease has increased. Hello.
Tell me, Padma.
The progression have been continuous over the past 2 to 3 decades, mainly because of unawareness, and both from the patient side as well as from the doctor side. The patient also does not have a regular checkup like in the Western world, because mainly I think in India cost is the main feature, and doctors also do not advise the proper investigations. Instead of that, we have a common phenomenon called as master health checkup, where the patient cannot afford it. In the beginning of our practice, we used to have some 6 or 7 investigations only and clinically oriented practice. So we had the main basic investigations, as the previous speakers told, like hemoglobin, creatinine, urine routine analysis with BT-CT, some 2-3, that's all. And patient could afford, and they would mean, and we used to do this blood pressure checkup and weight checkup very normally. But now the trends have changed, and I think the awareness, though it is there, people are afraid to go further, both physically as well as mentally, and also financially, what I feel in my practice, what is being done even today.
Thank you. Anuradha, do you think now we are talking of hypertension, diabetes, similar to kidney disease, are you seeing a more incidence of hypertension, diabetes in your practice in the last 20 years?
Yeah, first of all, sincere thanks to the team for giving us an opportunity to be in this forum. Yes, certainly the incidence of diabetes and hypertension is increasing very rapidly, very, very rapidly. And we find that most often we are not able to pick them up. And I comply with all the predecessors who spoke that the attenders need to be checked, and then the general checkup needs to include, when they walk in, now vitals are given importance, patients do listen to you, we check the SpO2. So in addition to that, getting their BMI done is another parameter in my practice. So certainly the rise is rapidly increasing.
Padma, now you see in a day roughly how many patients?
My practice is only in the evenings.
What about average?
It's about 20 to 25 patients.
In that, have you in the last so many years, have you diagnosed kidney disease from the symptoms as the first time in your practice?
Yes, sir. I have done it. and it has gone even to the level of transplant also.
Okay.
So I have seen even right from stage 1 to stage 4, most of them I have seen, and I have referred till the level of dialysis as well as transplant. And nowadays, because of the awareness, I think people are also realizing, and they are coming for regular checkup as and when told, and I think they are in good control, both in hypertension and diabetes, if they are little well educated and they are aware.
What about you, Anuradha?
Yeah, if it comes to me, I'm entering into my 4th decade of practice. So
you work, she says only in the evening, you work full day?
yeah, full day. I
And
have
average, how many patients would you see? And
So I find that the incidence is much lesser to me because my practice is preventive. So whether a patient walks in with missed period or with infertility or with fever, I make sure that I touch upon the other parameters, and none of my investigations go without serum creatinine or a urine routine. So these patients are picked up early, and I have lot of patients whose creatinine has not gone up at all. That in the sense that my preventive medicine is working for me. And rarely, or I think hardly, I've picked up any new case.
Padma, I think I really value your opinion about this master checkup. I get a lot of calls saying that, my own son, I've got 3 sons, 2 of them are doctors. One is the brightest, he didn't do medicine, he's a chartered accountant. So he doesn't know much of medicine, but invariably he'll call, somebody falls sick and he'll say, Dad, I want to full master checkup, or I want cancer screening. I always tell him, go to a physician or somebody first and then order the test. Blindly doing master checkup, in my opinion, gives actually more patients. I mean, there are a lot of theories whether it should be done or not. Actually, somebody in the morning was mentioning about this EGFR. In a way, I still believe, I'm old timer, I still believe in creatinine. Especially the EGFR now, the modern terminology of CKD. In my days, we never used CKD. 40 years ago, it was mild chronic renal failure, moderate and severe. Now it is chronic kidney disease, and 10% of the Americans, they say, have got chronic kidney disease. If you look at India, it will be like that. And the EGFR, actually, I am happy from a personal point of view, because my bank balance is increasing because of EGFR. Every day I have 1 or 2 normal software engineers who have gone for a master checkup, and they get the EGFR done, labeled as CKD. It is traumatic. So I personally feel EGFR is all right for research purpose, but day-to-day screening, I personally feel it's not. So I agree with you about master checkup. Now, in your practice, you said that you have seen from stage 1 to stage 3. I think, when do you think you would refer a patient with kidney? You diagnose first time somebody comes to you, you check the blood pressure is high, you've done a test, and you think there is a kidney problem. When do you refer to a nephrologist? What is your criteria?
So most of the time I go for these preventive measures, like regularly checking the blood pressure and keeping control of diabetes, obesity, and once in a month or 2 getting checked on serum creatinine and routine urine analysis quite often. I keep in touch with them. Previously they used to come to me, now it is through WhatsApp. So they are maintaining to a very great level. Only when I feel that the serum creatinine is quite high, more than 2, I feel that I should take a second opinion from the nephrologist. And moreover, I am a professor of pharmacology, so I think I know little more. So I try to maintain everybody till serum creatinine 2 with all counseling and maintenance of all these parameters, home-based monitoring of BP, then home-based monitoring of glucose, and the way they eat, the type of walking, everything I try to maintain them and try to tell them through WhatsApp or through phones. Most of the times, almost I follow them up till 2 months, almost on a daily basis, so that they will come to know what should be done without a doctor, at least for a month or 2, and be happy without a doctor, so that they can maintain themselves. So when it comes about 2, I usually refer to a nephrologist, and most of the times the consultation will be the same as I have told, and beyond that I leave it to the nephrologist itself to do so. But what they do usually is they give the consultation and they put it to me back, and they say to the patient that whenever needed, the doctor will tell to come to me, then we will have one more consultation. Otherwise, you can be with the same person for next at least 1 year.
I would like to answer this question. Coming back to master health checkup, when you try to teach them as to how it needs to be done, no, you don't succeed. So I asked them to go ahead with the master health checkup, come back with the reports, and I am going to add whatever is needed. That's one thing. Another thing is, once you diagnose that some patient is overweight, obese, pre-hypertensive, pre-diabetic, they are not mentally prepared to accept at all. So then I make it a point to utilize the services of a physician bar nephrologist based on the requirement. But certainly, as the creatinine is going up, as I find that the urine AC ratio is bordering 0.3, I caution them that they are the candidates for kidney disease. And once they cross 0.3, I don't keep them at all. I send them for an opinion. Invariably, the nephrologist refers back saying that electrolytes are normal, etc., etc. But my work is over. So I always prefer to refer to the concerned consultant much earlier than a complication sets in.
It's interesting. The studies in USA, even in a developed country, nearly 40% of the family physicians don't refer even when they know somebody has got kidney disease. I would like a word of caution. Somebody who's got, say, creatinine, even 1.3, 1.4, 1.5, whatever, with proteinuria, I think we must find out whether the kidney disease is reversible, because the basic test I would do is an ultrasound. In fact, when I started my practice in 1985 in India, in Bangalore, we had only one ultrasonologist, Dr. Ramurthy came with me, nobody was there. But I would refer every person for an ultrasound, because I thought, I still feel ultrasound is part of clinical medicine. Because olden days, when we were MBBS students, there was always, the professor was always right. There will be splenomegaly, was some lump, and nobody knew what the answer was. So with an ultrasound, so I think ultrasound will tell us the size of the kidney, whether small kidney, big kidney, polycystic, or whether you got one kidney, because now 1 in 1,000 has got one kidney. In 95, when we had kidney scam, people would go for some other surgery, but before that, some abdominal surgery, we would do a scan to say you got two kidneys, because they've gone with one kidney, born with one kidney, they go for an abdominal surgery, come back, then they'll be accused saying the kidney was stolen. So to that extent, even kidney trays were not being used in hospitals in 95. You must all know that. 95, even I was one of the accused of stealing kidney. Even I was nearly arrested in 95 for so-called kidney stealing, which is quite scary, because people didn't know about kidney. They thought kidney could be stolen, exported. So I think ultrasound should be part of your basic practice. Any proteinuria, it may be due to fever, whatever it is not normal. Let's be very clear. Urine protein is not normal. It has to be investigated. So simple urine exam will tell us a lot of things. Other thing which I would like to know, in your practice, Dr. Padma, do you see anemia in your practice?
Yes, we see.
Okay. And what do you do if there is any patient comes to you with obvious pallor, the hemoglobin is low, they come to you with anemia? How do you investigate? What do you do?
Again, we go through these investigations and also a scan and see the age, what is the age of the patient. Accordingly, we do the treatment or refer to the concerned person.
Yeah, anemia is one aspect that I would never like to miss in any age group, starting from the kid who's just been delivered with me. I check the conjunctiva, and once I feel the patient is anemic, I just don't do a hemoglobin. Of course, if it is done, I get the detailed investigations to know her or his serum iron levels, peripheral smear, the RBC, etc., etc. And I make sure that none of our patients walk into any other consultant or any other hospital with anemia. I tell my patients, I am ashamed that my patient is having such low hemoglobin. So hemoglobin is one target, obesity is another target, and osteoporosis, of course, in addition to taking care of hypertension and diabetes. And my sincere request to all my colleagues is, let's not just do a simple hemoglobin. Let us do the serum ferritin levels, let us do the peripheral smears, let us not forget to recheck the blood group that our patients have, and also caution them about the complications of overweight and obesity, and keep also a small space to talk about osteoporosis, which is another chronic killer for all of us. And not the least, the complications of hypertension and diabetes. We never touch, because once a doctor prescribes a tablet for hypertension or diabetes, it goes on and on. And whenever a patient walks into my clinic with menorrhagia, I ask her, ma'am, I am diabetic, my sugars are normal, my doctor is taking care. All that I tell her is, I would like to go through your reports. I find that for the past year or two, she hasn't visited her doctor at all. And she says, my doctor, poor doctor, we are blamed, that our professional colleagues need to know. You need to cross-check, and you see that you have never told them what they blurt out. So it is up to us to take a little more time out, be patient, to talk a little more about diet. If you cannot talk about the diet, do utilize the service of a dietitian, but let's make sure that all our patients have better lifestyle, because that is the secret and that is the need of the hour for all our patients. They don't listen to you, doesn't matter. The prescription paper is with us. Make a note in the corner. Advice scan, Sir scan. Yes, all my patients have to have a dental checkup. They have to have their eye checkup and a scan the moment I find that she is hypertensive. And Dr. Ranjan Shetty told us that in the first visit, he usually doesn't start antihypertensive. But I have two challenges to face. One, it is moderate to severe hypertension. I wouldn't want my patient to land up with a complication. So I make a note that BP needs to be monitored, rechecked, and I send her back forth and recheck and get the ECG done if the patient agrees. But I tell them I'm starting a small dose of anti-diabetic or whatever it is. Anti-diabetic, no. I wait for the FBS and PBS the next day. So request to all our professional colleagues, all our doctors is, please make a note on your prescription paper that the patient has refused. Let us not back out on telling these things to our patients.
I think anemia is a very important topic in my own practice, and what Anuradha said is very true. Peripheral smear is a simple test. Normally, iron deficiency anemia, you have microcytic hypochromic anemia, whereas anemia of chronic disease, like chronic kidney disease, is normocytic normochromic. India, we have a challenge because we have iron deficiency, which is very common. But I think all anemias are not iron deficiency anemia. I will tell you the story. This was when I started practice 40 years ago. I had a referral from Mangalore. My own professor of medicine had seen a patient with anemia. He was treating the anemia with so much iron that the patient had become like a magnet, literally. And the patient was actually being flown to Bombay to see a hematologist, Dr. Advani, because we didn't have a hematologist in Bangalore at that time. As she was boarding the flight, she had seizures and fell down. And then they checked the blood pressure, it was very high. They did a creatinine, was 12. The anemia was actually chronic kidney disease. This is a real story. And then she was referred to me to Bangalore. We found out she had got small kidneys, CRF those days, and then we did dialysis, transplant, different story. So I think anemia is very important day-to-day practice. All anemias are not iron deficiency. It can be due to so many other things. Even if it is iron deficiency, it may not just, it may be your stool occult blood. I know my colleague who had anemia in a routine checkup, he's a doctor himself, and then a stool occult blood showed positive. Then they did a colonoscope, he had to see a colon, and then he got operated. So anemia is very important in your practice. Same, you're talking osteoporosis, calcium, phosphorus, these are also indicators to tell us about chronic kidney disease. That is in my opinion. Now, you were telling me, Padma, about that you're following up patients from stage 1 CKD to transplant. I think it's very important as a nephrologist, we must tell you that we want family physician to be involved in our practice. When I do see a patient with chronic kidney disease, say with a creatinine of 2 or 3, I would want them to go back to the family physician. Then I would like to work with them, because as the GFR starts coming down and they reach a stage called CKD4, we would like them to be prepared for dialysis. So if, as family physician, if we can talk to you and you'll be able to convince them to have a vascular access, because when you talk of chronic kidney disease, for dialysis, we need something called vascular access. That is called AV fistula. In dialysis, we need 200 ml of blood every minute, and that blood cannot come from ordinary peripheral vein. So we do something called AV fistula, connecting the artery and the vein. So the forearm veins are very important. So that can start with the family physician. We start counseling, talk to them. I think that's why this forum like this, which Kidney Warrior Foundation organized, for us to tell you that the treatment or the planning for CKD starts with the family physicians. That's very important. That's why I said that diabetes, in fact, one other thing which I see in practice is somebody who's diabetic for many years, they are on insulin for a long time. And then in about 15, 20 years, their insulin requirement comes down. They're very happy. They come and tell me, sir, namdu diabetes ella cure agbitide. That is the stage with my friend, Dr. Prasanna Kumar is not there, the former president of the Diabetic Association, tells me it's the stage where patient is happy, but doctor not happy. Simple urine test will show proteinuria, do eye checkup, there will be retinopathy. This patient has got diabetic CKD. As the kidney failure worsens, your diabetes gets controlled. They go into frequent hyperglycemia. They are happy diabetes is getting controlled. So this is one thing, as family physician, please be aware. Your patient with diabetes for many years, if the sugar is getting controlled easily, it is something you have to worry. You must think of kidney disease. So that is one. Now, I would want you to ask me or anybody, any questions you have from your side, what do you want us to do?
Yeah. Before I ask that question, I'm into mainly obstetric practice. So my care of the patient's kidney or the prevention of disease starts from day one.
Excellent.
She comes with infertility. That is when I tell her that her levels, folic acid level needs to be good, and she needs to be healthy mentally and physically before she conceives. I tell them very clearly with that whether she conceives or not is not my concern, but taking care of good health is important. So my counseling starts right from there. And when grandkids and daughter-in-laws and daughter-sons come to me, I make sure that they are with the patient when we talk about the disease, so that they are aware as to what they need to do to prevent a disease. And that's it. Now coming back, you asked questions. I have a whole lot of messages. I have made a whole lot of messages here.
Please go ahead.
Encourage all to have a family doctor. I keep telling my patients, I
am with you.
Yeah, I wish I had a family doctor like you, is what I tell my patients. Do look a little outside your specialty when you're seeing a patient. I'm a diabetologist, I just check the sugars. I don't talk much about osteoporosis or otherwise. So I request our pediatrician friends or our obstetric friends and others also to take a look. And then when we check vitals, make sure that we include serum creatinine and urine routine, which you have all spoken already. And encourage, this is one important message, encourage cross-speciality meetings. I am with IMA, immediate past president, IMA Bangalore branch. I have been making very sincere attempts.
Thank you.
Since
proud of you.
More than since 2017 to see to it that that all specialty doctors take part in the webinars and CMEs that we do. And I find that IMA is a good platform for that. And when to refer, I have already been clear, not after patient sets in with complication, much earlier to that.
Actually, the next session is going to be on with the gynecologist, and what you said is true, because kidney disease gets manifested during pregnancy. Invariably, you'll be surprised to know, every month I have one young lady, she gets married, goes on honeymoon, and comes back with vomiting, and the whole family is rejoicing, morning sickness. And I do tests, she's got advanced kidney failure. And when I tell them that the girl has got chronic kidney disease and going on, then they get angry, and then they say, oh, this girl has hidden the story, and they want divorce. A different story, but this occurs quite often, so it's very important it starts there. Padma, you have any questions or your comments from your side?
I have been doing the same what you said just now. Whenever I happen to counsel the patient or take a second opinion from the specialist, I will be in touch with the specialist, and then they will send it back to me. And these things are going on at least with about 2 to 3 dozens of patients what I have now. And I think whatever I wanted to ask, she has covered it up, most of them. And I feel interpersonal relationship is more important, and taking at least 20 minutes for every patient for any specialty is important.
Correct.
It is not just writing a prescription and sending it, and that prescription also should be very legible. Nowadays we don't see any legibility.
So good doctors should have bad handwriting, it's not true.
Yeah. And WHO has also changed now, writing in capital letters, no abbreviations, etc., etc. So all these should be taken care from the doctor's side. At least we should be true to ourselves that we are doing a good job to the patient who comes to us. And the most vitality is the one that we should spend some time, which Our doctors are not at all doing that. And I think most of the people, most of the patients are doing window shopping nowadays rather than sticking.
Google shopping.
When I started the practice, people used to stay with us for number of years and even generation to generations. I have 4 generation patients in about a dozen of families. But that is not there anymore, and they go on asking second, third, fourth opinion, which should almost be like abandoned, and patient should settle himself so that he gets a good consultation also, and there will be more preventive measures rather than curative, which may not be possible for many of them.
And I would like to ask Vasundhara from the, she is the founder, CEO of this organization. We are all in this to support the patients. And from the patient perspective, Vasundhara, you have anything to ask or comment to us and the GPs? What would be your advice?
What we talked about, the second opinion, is very important. You know, my son was detected with kidney disease when he was 15. He was bedwetting, and at 10 years we had gone to a urologist, and we were told that he'll outgrow it and not to worry. And then when he, for 5 years, in 5 years he'll outgrow it. So 5 years later he had a kidney failure. When I went and met the GP, fortunately she tested his blood pressure, and immediately they asked him to do the creatinine test. And by evening we had the report, and we had gone to Dr. Gandhi, who was the nephrologist. He said, if you had come 5 years before, I would have done a corrective surgery for the reflux, and he would have saved his kidney. So the second opinion, whenever in the group any member is talking about a doubt of one doctor, ma'am, I don't know what to do, please take a second opinion, because you have to be satisfied. It's not because of, then they do 3, 4, that is something that is leading to more confusion. So 1 or 2 you take, then you can make a decision. So coming to another point that I've always been wondering is that very often some medications are given, BP tablets or medications are given, and some of them have this warning about side effects, about it leading to kidney disease or something. So is there any check on the type of medicines that are given?
I think it's important, Vasundhara, especially non-steroid and most of them, the painkillers, they kill the kidney also. We see this in practice, I'm sure from your side. Yes, Padma.
When we are giving medicines, we should not put any fear on them, first of all. We have to advise medicines, and every medicine has a side effect. With that sort of therapeutic dose, there will be some small side effects where the patient should not be put into any fear. He should be told to check it on. Like for example, AC inhibitors and ARBs, if they can check it up once in 3 months or 2 months for
the creatinine,
hyperkalemia, especially hyperkalemia.
Okay.
For cough, I think it will usually settle within about 4 to 6 weeks. Whereas, and even first dose hypotension, we can tell them to start the drug at night. And also, the system works at night for these AC inhibitors and ARBs, so the drug should be given at night, where most of us start giving in the morning. So these are small fallacies which are going on because people don't know about chronopharmacology. That is the one, most of the things it is the representative driven medications that what most of us follow. So if at all we follow chronopharmacology, there will be proper maintenance of whatever disease we are treating to. And small side effects should be seen with investigations only, like hyperkalemia. So instead, by chance if the patient does not have so much of finance to get these investigations done, at least we should be fair enough in telling that the food that causes hyperkalemia should be prevented. For example, that big bananas, they are known to produce increase in potassium levels, or coconut water. These are the small things what a normal man can also understand. Because you are on these drugs, try to cut off all these things and don't use it very often. Most of them are very fond of using coconut water during summers. So tell them not to use this, because this plus the drug, there might be increased hyperkalemia where he might land up with another doctor or even a casualty for tachycardia or whatsoever it is. So these smaller things should be counseled That's why I told at least 20 minutes should be taken per patient to address all these things. Otherwise, what happens? All these smaller effects, and even now, for example, everybody would have got knee pain, and everybody knows painkillers. But after 55, there is a consensus by rheumatologists that only one tablet should be taken per week without prescription or without consultation. Beyond that, they should be in touch with the doctor to take the second drug. Or you should use a safer drug like paracetamol only, which will not touch the kidneys, so that he is quite safe.
Thank you, Padma and Anuradha. Now we are short of time. I'm just going to open the audience just for one question. Anybody else got any question to all of us? Okay, if there are no questions, I think we would like to close. Thank you, Padma, Anuradha, Vasundhara. Thank you, Kidney Warrior Foundation, for giving us an opportunity to discuss with the family physician. Thank you.